to treat and to pursue this career. And it's a very good opportunity to be here, and thank you all for this. I'm going to talk a little bit about ocular surveillance, the tumor control portion of it. I won't get into technical details as much as I will be explaining a little bit about why we do the things we do when we monitor you. So when we talk about tumor control, so when we talk about tumor control, what does it mean for us as caregivers? First, we'd like to treat the patients in a way that the tumor won't grow. And second, we would like to treat them to see that there isn't any tumor recurrence. So first, I would like to tell you a little bit about what does it mean to have no tumor growth. So uveal melanoma, as you know, is categorized based on several categories, but most of them is based on the site. It can be either in the anterior component of the eye or even the posterior component of the eye, which is much more common. Just a moment. And the main treatments that are being done today are mostly resection of iris tumors when it's in the front, or enucleation based on several other criteria, and also other modalities such as radiation with a plaque or proton beam. And usually these modalities have very high control rate, between 90–95% to about 100%. So what about the possibility of tumor recurrence after this treatment? Although very successful, these treatment modalities, tumor can recur, and it can happen. And we need to monitor this tumor recurrence and to see where the tumor recurrence happened, what is the timing of it, and which type of it, and after which modality. Recurrence rate after the surgical resection, as I mentioned, can be up to 2% after enucleation and up to around 5% after iris tumor resections. After plaque radiation therapy, and this is what I would be talking mostly, can occur about 5 to 10% of cases. And sometimes when the tumor is treated with laser TTT, it has a much higher recurrence rate, and therefore it has been relatively abandoned. So it's also important to figure out the site of possible recurrence. And this is why when we monitor you, we usually tend to check the margins and the height of the tumor. So we would like to monitor to see if there's any margin stability or whether the margins are actually expanding. So this is why when we examine you at the clinic, we seek for margin stability. And it's also important to see if there's any central recurrence in the height of the tumor. Therefore, when we monitor you, we don't only monitor the margins of the tumor, we also monitor the height of the tumor. And we usually do it with ultrasound to see if the tumor hasn't grown, or better yet, is getting thinner. And these are all signs of tumor control. So here is an example of a patient in an iris melanoma, and you can see it in the left picture, which was resected. You can see it in the middle picture. But when he was followed, you can see there was a small recurrence margin at the margin up top marked by the arrow. So this patient underwent further resection of this margin later on, and for completion of tumor control, he went plaque brachytherapy treatment with good results. And here you can see another patient, and now we're talking about the posterior uveal melanoma, choroidal melanoma, which was treated with plaque brachytherapy, and on follow-up, there was some marginal recurrence at the posterior edge of it, and you can see it marked by the red shape. So this patient was treated with laser treatment, additional laser TTT, and he had good tumor control rates afterwards. Nothing came back. So we talked a little bit about the tumor marginal surveillance, but here's an example of a patient with recurrence not only in the not in the margins of the tumor, but rather in the central part of it, and you can see it encircled with this red circle here. So this patient was treated with plaque radiation once more, and the tumor was under control. So in general, when we speak about plaque brachytherapy, and this is the most most of the time we do this treatment, we can say that the recurrence rate is relatively low. It's only about 5% of the cases. Usually it's marginal, and usually it occurs about the first 5 years of treatment, and mostly in the first 18 months of treatment. And this is actually what's driving our monitoring regimen. So this is why we do in the first year every 3 months a visit to see if the tumor is not recurring. And after that, after the first year, up to the 5th year of follow-up, we do it every 6 months. And then thereon, we do it yearly, a yearly examination, because the risk of tumor recurrence actually get lower after this point. So although we do see low rate of recurrence, what can we do if it happens? So we can try and resect the tumor once more if it's an iris resection, as you've seen. And we can perform a nucleation if the recurrence is too extensive and inevitable with other treatments. And if it's suitable, we can consider another plaque brachytherapy application, and you saw some examples of it. Both approaches are relatively high, and sometimes even a laser TTT retreatment can be done, but usually it has a much lower control rate. So with this conclusion, I will pass the floor to Dr. Singh. Thank you very much.
So I'm just going to talk about vision loss following a radiation treatment. And right here. Okay. And so the technical word would be radiation retinopathy. Retinopathy, retina disease from radiation. And it's iatrogenic. That means it's induced by the treatment. And why do we keep using radiation? Because radiation is very effective treatment. We know, we just mentioned 95 to 900% control rate. And it's surprising when I say that it's been there for more than 100 years. So uveal melanoma has been treated by radiation for more than 100 years. And we still are using it because highly effective. And I can also say that despite all the new things that are coming, it's not going to go away, because highly effective, and we have data for so many years. So what we can do is to control or minimize this radiation complications. The only problem with radiation is radiation retinopathy. And if I can control that part of it, then I'll be in a perfect situation. So that's what's happening. I'm going to highlight just a few things about it. But you'll hear about trials that are coming either to replace radiation altogether, or to decrease the dose of radiation, or to work around it. All aspects of this are being studied. Today or this morning, when this starts, I'm going to touch very briefly just upon the radiation. So what does it look like? It causes some hemorrhage inside the eye, causes leakage inside the eye, all the yellow material, and the tumor is at the bottom. So the tumor looks good, but this vision loss depends upon how far the tumor is from the optic nerve and the macular area. And the fact of the matter is, it's a very frequent complication. Approximately 50% of patients will get it. There are many studies to show that numbers vary, but one can say roughly 50% of patients will get it, and shows up at about 2-3 years after radiation. So obviously it starts when the radiation is done. By the time it shows up, it takes that many years. But why is that? Because the retinal cells that have been injured can still function for a while. And when those die, the cells that are supposed to replace them are missing or injured. And it takes, so it's like, imagine you have a column of army and all the soldiers are wounded, but they look fine when you look at them. And only when you say march, that they can't march. and they start to die or show up or fall down. And this is how the cells are. They are injured and they're there and they're functioning. And when they're asked to replace the cells that have died, there's nothing to replace them, and it takes that long. So it's not that there was no injury. Injury happened at the time of radiation, of course, but it took that long to show up. So it's hard to understand why it shows up later. And now I can say in general, we say if it doesn't happen for 5 years, it's unlikely that somebody will get it. Okay, that's the other thing. So it's frequent and it's delayed. And the damage is mostly to the retinal vessels. So the retina has vessels, cells, pigment, choroid, optic nerve, all the things. But radiation retinopathy is predominantly disease of retinal vessels. And we have techniques and technologies now to see retinal vessels. And there are different scans, and you can study them, and you can figure out which capillaries are damaged, et cetera, et cetera. So there are ways to study it. And it shows up in some ways resembling what people get in diabetes. So diabetic retinopathy and radiation retinopathy have similarity in appearance, pathogenesis, except that that's due to diabetes and this is due to radiation. But they kind of look the same. And we are deriving treatments for radiation retinopathy from diabetic retinopathy. So what works in diabetic retinopathy is now coming into radiation retinopathy. We'll talk about that as we go more. It's not moving forward. Okay. So give you a case. Another patient was treated maybe 20 years ago now, more than 10-year follow-up. Good vision, slightly down. And you can see the tumor little blip here. Is this pointer working here? Okay. Here's the tumor. Here's a little detachment. Here's the tumor. Here's the optic nerve, and here's the macula. Not really affected, but tumor seems to be close to this area. And he was treated with, it's a small tumor, technically small to medium-sized tumor. Why is it not moving? Huh? Try again. Okay. And you can see after treatment, the tumor is smaller, the detached retina is gone, and you can see some atrophic reaction up here. Right here, you can see with optic nerve and macula still looks normal. And we say that his vision, there is some lag here. I need the next slide. Okay, his vision is, maybe not the computer just use this. Yeah, okay, so vision is 20/20 and he's 10 years out. So like, okay, go back and study this case in detail. So why was his vision so good? Because the radiation dose to the disc and macula was below a certain threshold. So we know it's dose dependent, and you can go back and analyze the radiation that Dr. Su's group makes for us. We say, oh, this optic nerve and disc and macula got dose of radiation below a certain level, and therefore the vision was good. So there are certain predictions that we can do. So you say, I'm going to have radiation treatment, and you ask the question to me and say, oh, yeah, you have a chance of losing vision. We kind of very vague about it. But the fact of the matter is we can be precise within certain limits because you need large number of cases for this kind of mathematical predictions. So all you have to do is put all the variables into this big formula and see what happened to the patients and then say, okay, now I have a new patient and what will happen to that patient. So you can use this kind of prediction modeling. And we did publish this almost 9 years ago. And in fact, this will be used in one of the trials that IDEA is using, this model of prediction. So you can say, today you're going to have treatment. We can say roughly what your vision will be 3 years down the line. There are ways to input that. And in fact, we have see if that will work. Actually, an app made out of this, okay? So you can go in and put the numbers and give you some prediction probabilities there. So it's all mathematical, but it's possible. Yeah, no? Yeah, see if that happens. So imagine it's like Google Maps. You say, oh, I want to go here. Or best of plane flight, okay? Your long flight, say I take long flights to India, 15 hours, 16 hours. It tells you land at 3:10 p.m. And 15 hours before you land is telling me I'm going to land at 3:10 p.m. Plane weight, height, wind, so many variables, yet it's pretty much close within plus minus 5 minutes as to when you're going to land. Well, how did this figure out? Well, if you fly a plane 10,000 times and keep figuring out, then you know what will happen, right? You don't know about driving it, but you have prediction, right? That's machine learning for you. This is something similar. Do you happen to have that or no? Okay. In any case, there's a link, and if it doesn't work, it's fine. Okay, no worries. Okay, so it's possible and it's been done, and it will be hopefully validated by other people too. Let's come back to the slides again. Okay, so now using all this, we say, is there something new for radiation retinopathy? Am I able to? Okay, I'm still not able to move my slide. Yeah, so coming back to radiation retinopathy, so we know its onset is delayed, we say it's frequent, we say it resembles a diabetic retinopathy, we say it's dose dependent, I showed you a case, and it responds to treatments that are working for diabetic retinopathy. And there are other things like tumor location. If the tumor is in the macula, then the vision will be gone forever. And of course, there's a risk of radiation damage to the optic. So these are the things that confound things and give you the final kind of vision that you get. So these are little parts of the puzzle trying to solve and figuring out the vision loss. But also there are many things that we do not know. And we say we do not know what will happen without treatment, but we know they'll lose vision, but like how much and how fast, we really don't have that sense of it. Which patients to treat, and what drugs, when to start the treatment, and how often to inject, and which agent to use first, and when to switch agents. So all of this is still new because these drugs are new and coming into radiation retinopathy, and we don't know all of these questions. We do not know. I see some of my patients who are getting these treatments, and I come up with the best logic I can. But the fact is, we don't have any numbers to support any decision. We have theories for it, we have logic for it, but no numbers, no real evidence. So to answer some of these questions, we have started a trial. And just to think about it, in the business of retina, let's say this is a retinopathy, there are two kinds of trials happening in the United States. Half of them are industry trials, companies that have product and they want to test it and sell it. And there are others driven by federal funding as a consortium. This is kind of independent of that. And this is part of that trial. This is my idea, which I pitched to them. And it's happening now across the nation. Just to go through it as to what this is, and I won't go through all the technical stuff, just make it very simple here, come to the key points. So we're looking at multiple injections or steroids or nothing. So three kinds of treatments. And we're trying to figure out whether these treatments will reduce the risk of vision loss. And we're also comparing the natural history of disease with kind of this fancy new technology imaging. So you have a control arm, you always need a control that were not treated. And this is randomized. Randomized means is luck of the draw, right? So at the time you choose, you say what the computer tells me, you'll get either this kind of injection or the other kind of injection or nothing. Up front. And down the line, if the disease happens, then we treat it differently. So that's the objective. This is a $13 million trial. $3 million trials. $6 million has come from NIH, NCI, NEI kind of funding. And other $6 million has come from the drug companies who are trying to get approval from the FDA for the drugs that they're giving for free. So if it works, then these companies will go to FDA and then be able to sell it, and the insurance will get the approval, that kind of process. So it's kind of a consortium and combined hybrid model. And that's this 600 patients already started. We have almost 50 some patients already done. And the trial is going very well. So one is faricimab, Iluvien, and observation. So there are attempts being made. This will take maybe 3 years by the time we get the results, but there will be some evidence to what we can recommend. And I think this will be very useful because radiation isn't going to go away completely. It will be modified, avoided for some tumors, medium-sized tumors will still have it, etc. So just as of now, 85% of uveal melanoma are treated by radiation in the United States. So that's the most common treatment, 15% enucleation cell resection. So this isn't going anywhere, and they were trying to go around it to minimize the impact of vision loss. Thank you so much.
Great, thank you both. And we are going to continue with this session track, and then we'll have all of the speakers come back up for a Q&A panel at the end. So we'll just keep moving through to our next presentation, which is going to be on DNA testing, who, when, and why, from Meghan DeBenedictis. And all of the bios for all of our speakers, their full bios are in the program if you would like to read those. But just a brief bio for Meghan. She is a licensed certified genetic counselor here at the Cleveland Clinic. She's a clinical professor of ophthalmology and specializes in hereditary eye disorders. She's also the director of genetic business development for the Cleveland Clinic's development of medical genetics and genomics. So please join me in welcoming Meghan.
Thank you very much. I just want to say it's always intimidating following Dr. Singh, who I admire and respect so much. I really appreciate the invitation to speak with you all today. I have no conflicts of interest. So I was tasked with the lofty goal of trying to talk about DNA in about 15 minutes. So I will do my best to provide that education. So DNA is essentially the instructions or the blueprints for our bodies. It tells our bodies and our cells within our bodies how to grow, how to function, how to develop properly. Our DNA is organized into these kind of wormy looking structures called chromosomes. So if we were to take one cell and look at it underneath a microscope, we would see, does this pointer work? We would see what we call a karyotype, or a picture of our chromosomes, our genetic material. And we're all supposed to have 2 copies of each of our chromosomes. We get 1 chromosome copy from our mothers and a 2nd chromosome copy from our fathers. The last pair of chromosomes down here are the chromosomes that determine biological gender, whereas females are supposed to have 2 X's, and then men have an X chromosome that they inherit from their mothers and a Y chromosome that they inherit from their fathers. And along these chromosomes are individual genes. We can have problems with our chromosomes. So sometimes we can have chromosomes where we have a missing copy. This is something that we can see in ocular melanoma. So some patients, the tumor, the DNA of the tumor has a missing chromosome number 3. We can also have changes in the DNA of the tumor on chromosome number 1. Sometimes we can have extra pieces of chromosome number 6. We can have changes on chromosome number 8. So this is something that when we look at the DNA profile of a tumor, we can look to see what does the chromosomal structure look like. Do we have extra or missing pieces of that genetic material? And sometimes that can be associated with different types of prognoses. I mentioned that along the chromosomes we have our genes. So our genes are basically sequences of DNA that encode specific proteins. We have over 22,000 genes in our bodies. And a protein is basically a little machine. And again, it has a very specific role. We have genes that are responsible for tumor suppression. And so you can imagine if there is a mutation, if a tumor suppressor gene is not working the way that it should, it then is going to allow tumor or cancer to form. So this is something else that we can do when we're analyzing genetic makeup of a person or of a tumor. We can look at the gene level to look for specific variants. And our DNA is made up of an alphabet of 4 letters, these C's, T's, G's, and A's. And when we do genetic testing, we essentially read through the DNA sequence of these genes, and we look to see if these letters are in the proper sequence or order. And they're supposed to be in a very specific order in order for that gene to make the protein and do the job that it's supposed to do. So we look for spelling changes in our DNA or our genetic information to see, is an A substituted for a G? Are we missing a couple letters? Are there a couple letters extra? Again, that gives us a lot of information about how the specific genes are working in our bodies and what they may mean for outcomes. So the most important piece of information I probably want to highlight today is this difference in genetic testing. We have genetic testing on a somatic level, but also on a germline level. And this can be a really confusing thing for patients and for families to understand. Somatic genetic testing is when we are analyzing the DNA of a tumor. This is DNA that is not heritable. It's not genetic. It's not passed down or shared between family members. It is DNA that is unique to the profile of that tumor specifically. This is different from what we call our germline DNA. Our germline DNA is the DNA that is present in every cell of our body. This is the DNA that made you you. This is the DNA that is shared or passed down from parent to child and shared amongst other relatives within a family. When we're talking about somatic DNA analysis, specifically in the ocular melanoma context, we're thinking about, again, chromosome number 3 loss. This is a largely known prognostic factor for ocular melanoma. And again, we can have other chromosomal aberrations that can impact prognosis. And then there are specific genes that we can test for, and there are others certainly as well that we're learning about. But again, if we look at the specific DNA sequence of some of these genes within the tumor, that can give us prognostic information. And so those of you who may have had genetic testing done on your tumor, these are some of the things that the genetic testing lab may have been looking at to help give you those different classifications that the patient and caregiver panel were mentioning earlier, class 1, class 2. Certainly there are other factors that go into that classification, tumor size, location, all of those things. But from a genetic perspective, these are some of the things that are analyzed. This is different again from germline testing. When we think about cancer as a broad category, the vast majority of cancer, 70–80% of the time, is what we call sporadic. We don't have a clear understanding or explanation as to why cancer happens. It's one of those very unfortunate things that just occurs. 5 to 10% of the time, cancer is what we call hereditary, meaning somebody has a genetic mutation in a gene, and that genetic mutation is predisposing or increasing that person or that family's risk to developing cancer. When we are able to identify a genetic mutation, a germline mutation in these families or in these patients, in some cases we can guide ongoing future cancer surveillance and give very specific recurrence risk information for family members. We also have what we call familial cancer, which is a situation where we are seeing cancer in a family much more likely than we would expect to see just based on chance alone. However, when we do genetic testing on them, we're not able to identify a specific mutation that would explain or be causative for it. And so for those families, we kind of err on the side of caution and we, quote recurrence risk and guide cancer screening based on the family history. When we get into talking about the genetics and the heritability of ocular melanoma, from this side, about 5 to 10% of the time, cancer as a broad category is hereditary, meaning we have an identifiable genetic mutation. For ocular melanoma, that percentage is about 2 to 4%. So about 2 to 4% of patients or families that have ocular melanoma have an identifiable germline mutation that, again, this was present in their DNA. They were born with it. There was nothing they didn't do that would have, necessarily caused them to develop that condition. We have identified some very specific genes that can cause or predispose individuals to developing ocular melanoma, with the BAP1 gene being the most common. So who should consider germline testing? So people who are getting diagnosed with ocular melanoma are oftentimes getting somatic DNA testing, again, to help with that prognosis and guide treatment decisions. But considerations for germline testing are a little bit variable. A recent study showed that approximately 1 in 7 individuals with melanoma harbored a clinically relevant hereditary cancer susceptibility. And some of the things that we would consider in whether or not somebody should get germline genetic testing is family history and then other personal cancer history. So if there's a family history of uveal melanoma, if there's a family history for cutaneous melanoma or other types of cancer, again, if you have a family where it just seems like there's a lot of cancer in this family, those would be individuals or families to consider germline genetic testing. And then similarly, again, personal family history. So multiple types of cancer within one individual, there may be something genetic that is, predisposing that individual to developing the types of cancer that they've experienced over time. This is different from metastatic cancer. So when we have a patient who has ocular melanoma and that ocular melanoma metastasizes, that's kind of a separate distinction from an individual who has had multiple primary types of cancer. There's this big question of when to consider testing. So again, at the time of diagnosis or at the time of surgery is when individuals with ocular melanoma would consider somatic testing. Germline testing can really be done at any time. This can be done at any time throughout a patient's life. We can do this through a blood sample or a saliva sample. And again, we encourage a consideration of genetics referrals for, greater than or equal to 2 melanomas or cancers within either one patient or within a family. Why? Why get testing? Again, the somatic DNA analysis can really help provide information regarding prognosis, risk for metastasis. In some cases, it can guide treatment decisions. And then from a germline perspective, it can help with personal future cancer risk assessment and cancer screening recommendations. So beyond that of just, is this ocular melanoma going to metastasize? And again, we think about, liver, brain, you guys all talked about that earlier today. But are there other types of cancer? Do we need to be worried about breast cancer? Do we need to be worried about pancreatic cancer? Are there other types of cancers that we may be at risk for because of a germline DNA mutation? And then again, to guide recurrence risk information for family members. That is the other reason why some individuals would consider germline testing. Again, somatic DNA testing, I talked about loss of chromosome number 3 or monosomy 3. This is, again, associated with a poorer prognosis and higher risk of metastasis. Uveal melanoma or choroidal ocular melanoma can have other chromosomal aberrations that can have even a higher associated risk of metastasis. We also know that in some cases, patients that harbor an EIF1AX, I am not the person who named all of these genes, they can have a prolonged survival rate and a lower risk of metastasis. And so again, having that genetic information from the tumor can be very helpful in this regard. We also know that BRAF mutations, which is something that we can see in cutaneous melanoma, there are certain BRAF inhibitors that could play a role in potentially treating metastatic disease. And so they're looking at this in the ocular melanoma space as well. BRAF mutations are less common, especially in posterior melanoma, but we can see them in some of the anterior melanoma tumors. I mentioned BAP1 earlier as being a more common genetic susceptibility. From a germline perspective, we can also see BAP1 mutations in the tumor as well that can be associated with a poor prognosis. BAP1 syndrome, again, this is a gene that is supposed to suppress tumors, and it does interact with the BRCA1. For those of you who have heard of like the BRCA genes, the BRCA1 and 2 that can increase risk for breast and ovarian cancer, the BAP1 interacts with that gene. It's in part of that same pathway. And so we can see risks for other types of cancers, again, beyond melanoma for people that have BAP1 tumor predisposition syndrome. So in summary, somatic genetic testing really is essential for patients diagnosed with ocular melanoma. Again, we can see some favorable or less favorable outcomes depending on that DNA profile. DNA analysis of the tumor does not always correlate with germline status. So somebody could have a favorable prognosis with their ocular tumor. That doesn't necessarily mean that there isn't something germline going on. And so again, patient's personal family history, personal history and family history are really important to consider, and whether or not germline testing would be indicated. And when in doubt, speak with your providers. We in the genetic space are always happy to meet with patients or families with these types of histories to go over, personal and family history in much more detail and make recommendations regarding germline testing status. All right, thank you very much.
Thank you so much. We always learn something new every single time. So thank you. We are going to move on to our next presentation. And then, like I said, we're going to invite the entire panel up to answer all your questions following this presentation. So it's my pleasure to introduce Dr. John Sue. He is the Enterprise Chair of the Department of Radiation Oncology here at the Cleveland Clinic Cancer Institute, Professor of Radiation Oncology at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University, and staff physician at the Rosa Alta Burkhart Brain Tumor and Neuro-Oncology Center and Taussig Cancer Center. So please join me in welcoming Dr. Sue.
Yeah, okay, great, thank you. Thank you very much for that introduction, and I want to welcome everyone here to Cleveland Clinic, and for those of you who are online as well. And I've had the honor and pleasure of being here at Cleveland Clinic for 35 years, did all of my training here. So I've been here a very long time, and really honored to work with Dr. Arun Singh, who's a world's expert in ocular melanoma. And what I want to do today is give you an overview of the systemic surveillance for patients. And also, as you've heard from the previous speakers, forums like this are really, really important for a physician like myself, who is very involved with research and education. This is what motivates and inspires me to do better each and every day for all everyone in this room here. So just to start off here, that's my conflicts of interest. So the objectives are to provide a very quick overview about the natural history of ocular melanomas, because that really helps frame how we think about systemic surveillance and how we think about staging for patients with ocular melanomas. Review some of the imaging modalities. We'll just briefly touch on some of the imaging modalities that are used. Discuss the timing and why we do the timing for these patients. And then to finish up with how personalization, and in this era of artificial intelligence and big data, we really want to figure out how to make the information more readily available and also make it more pragmatic, more practical for patients with these tumors. So just as a quick introduction, as all of you know, uveal melanoma or ocular melanomas are unusual, rare tumors. Each year in the United States, there are about 1,500 to 2,000 cases each year. So this really is under designation of orphan diseases. Although it's a very small group, advocacy groups like this are very, very important in terms of getting the awareness out there and really helping to advocate for better treatment options for patients, which actually has implications for other cancers as well. It predominantly involves the choroid, as you can see here, it's the back portion of the eye. You can see it's called sagittal or cross section of the eye itself. You can sometimes involve the iris, which is the colored portion of your eye, and then the ciliary body, which helps move the lenses of your eyes. Both sexes are equally affected by this disease. Now, when we think about cancer, we think about staging. Staging it gives us an idea of how well the patient is going to do with a particular treatment, how well they're going to do in terms of survival, which ultimately is the holy grail for cancer patients in terms of, how long am I going to live? And certainly, when you think about the word cancer, cancer is a very, very scary word for patients and families. And as a radiation oncologist, one of the key roles that I have is to educate patients and their families about what the diagnosis means, what the treatment options are, and how we can together go through this journey. So in terms of staging, the staging system that we use is called the AJCC, or the American Joint Cancer. Sorry, slides just went away. So we use the 8th edition, and the staging is based on several factors, most notably the depth, so how deep the tumor is, and also how wide the tumor is as well. If you can go back, I'll go back, that's fine. So there's just a diagram of a choroid melanoma, and the outcomes for patients with these eye tumors really vary depending on how big the tumor is. So in general, the smaller the tumor, the better your outcomes, the less likely it's going to spread to liver, lung, bone, brain. the larger the tumor, the greater the likelihood is. And that's why we use these staging systems. And we think about stage 1, which is the earliest stage. And these are the best prognosis patients. These are patients that are going to do the best. And stage 4 are patients that have metastatic disease. So I know this is a complicated table, but just want to kind of give you a perspective. So when I see a patient with a ocular melanoma, what I like to do is give a T stage. So it's T1, 2, 3, 4. End stage is really not really applicable because these tumors do not spread to typically lymph nodes. And the M stage, which is where it spreads to other diseases. Fortunately for patients with ocular tumors, the vast majority of these tumors are localized to the eye itself. So then we will look at, if you look at the bottom row here, we think about the depth. So if it's a small, if you think about the thickness of the tumor, you can see that if it's less than 3 millimeters, you're pretty much a T1, which is the better stage. And then depending on how wide the tumor is, so this will either put you at a T1 category, a T2 category, et cetera. So here you can see the most advanced are those patients that have a large tumor. So in this case, greater than 18 millimeters in the diameter and in thickness of being, here you can see 15 millimeters. So this is the best prognosis patients overall. These are the patients that have the more advanced disease and more likely to have spread to other organs, which I'll talk about in a little bit. So when we think about sites of metastasis of patients with these melanomas, the vast majority of patients, if there is spread to an organ, is to the liver. So the liver, here's just a cross section for those of you not, this is the human body. Here is the liver. The liver is a very important organ. And so it's estimated about 80 to 90% of patients will have, if there is spread, it'll be to the liver. Other sites of disease include the lungs, which would be here, and then also to various bones as well. For reasons that are being researched, we know that melanomas of the iris, or the color portion, right? If you have an iris melanoma, the likelihood of it spreading elsewhere to the body is very low. And then at diagnosis, about 3% of patients will have spread to other parts of the body. So the vast majority of patients that Dr. Singh and I see in consultation, the vast majority of them do not have spread. But we do want to figure out if there is any spread. That's where the staging comes in. So these are just some very rough numbers. Again, these numbers can vary a little bit, but at 10 years, if you have a very small melanoma, so it's 1 millimeter thick, the estimated 10-year risk of having spread elsewhere is about 5%. On the other hand, if you have a tumor that's about 6 millimeters, which is a larger tumor in thickness, your spread at 10 years is about 30% overall. So when we think about melanomas, we think about small, medium, and large melanomas. So if you look here for the smaller melanomas, 0 to 3 millimeters in thickness, it's about a 10% risk. Whereas again, you have a larger or deeper melanoma, 8 millimeters thick, it's about 50% overall. So this is where the staging is important. And also, depending on what the stage is, we can also look at other advances as well, options. So why do we do surveillance? So as I mentioned, the staging of a cancer patient is very important because as a physician, it just gives me an idea of how well the patient's going to do. And as Dr. Singh mentioned, that there are maybe some clinical trials that we are very focused on here at Cleveland Clinic and other big medical centers in terms of enrolling patients on the clinical studies as well. So when you do surveillance, you may find patients who have what's called oligometastatic disease, which means that the metastasis is maybe to one area. And I'll show you some examples of how we do radiation to try to control that tumor for longer periods of time. It also decreases the side effects and potential death from the advanced cancer. We also have greater therapeutic options for patients who are earlier diagnosed. So I'd rather see a patient who has one disease, let's say in a bone or in a liver or in a lung, rather than having multiple areas. And then also this is very important, is that clinical trials provide hope for patients with cancer. So whenever possible, we like to enroll patients onto clinical studies. That's really how we advance cancer care. If you think about standard care, we know we're at a certain level, but when we do clinical trials, we try something new that's different, that perhaps is not conventional, and that's how we advance cancer care. So in terms of the protocols, there's really no uniformity. There's differences in terms of how physicians think about how often you should scan, the type of images that you should use as well. So there's wide variation. So in Europe, just to give you an idea, the ultrasound liver is the most common, as I mentioned, about 80 to 90% of patients. If there is spread to another part of the body, it's in the liver. And you can see in Europe that they recommend getting ultrasound every 6 months for about 10 years overall. In the United States, it's a little varied overall. Some places we use ultrasound, some places use a CT scan. There's some uncertainty, and MRI of the liver will be shown. I'll show you some examples of that in a little bit. So it's really based on the histology. And now, in terms of personalization, we're using some of the molecular markers, the biology of the tumor, because we know some tumors are more likely to spread to other parts of the body. And then the duration of surveillance, I mentioned, varies from center to center. So the hope is by having these protocols, have some standardization, we can better understand the biology and what we can do to try to hopefully someday use medicines, drugs to actually prevent tumors from spreading elsewhere within the body itself. And again, if it's earlier diagnosed, if it's more limited disease, perhaps we can use immunotherapy, chemotherapy, targeted radiation to help address those tumors as well. So this is a study that Dr. Singh and his colleagues did looking at what's called low risk, which is the class 1 patients versus the class 2 patients, which are more advanced. And here you can see that they really found no difference between doing a scan every 6 months ultrasound versus doing the more advanced protocols, which is the case was doing an CT or MR scan every 3 months overall. And then here you can see that with this particular, for the low risk patients, 96% did not develop liver metastasis at 5 years. So again, a better prognosis group of patients. So just to give you some examples of what a radiologist will look at. So an ultrasound is shown here. It takes a picture of the inside of the body. For those who had an ultrasound that uses a transducer with some gel, you roll it over the patient. You get images in certain directions and just helps diagnose various liver conditions, including lesions within the brain. So it's really a less expensive, readily available imaging test that can be done for patients with to help screen for liver spread. We commonly use a CT scan in the liver. The advantage of using a CT scan in the liver is that you get a 3-dimensional view of the liver, the kidneys, the bones, other parts of the body as well. It's readily available. We're fortunate to have access to a lot of CT scanners here. And so we will typically get CT scans when patients are seen for the eye plaque brachytherapy. We'll get CT scans of the chest, abdomen, and pelvis just to see if there's any spread elsewhere. We use IV contrast to help delineate the vessels versus the lymph nodes in the area. And again, it's used to diagnose various conditions within the liver. If we have question about what we see on a CT scan, sometimes we see these spots, and sometimes the spots that we see on a CT scan may actually represent cysts or quite benign disease, which is not concerning. But if we do see something that's more concerning, that's where we get an MRI scan. MRI scan gives us a better picture. So you can think of having someone who wears glasses. If the glasses are not very clear, if you have better glasses, you can see more clearly, you can read more clearly. And that's what an MR of the liver provides us, and it helps detect lesions that are less than a centimeter as well. So it's actually more sensitive than what we can see on a CT scan. We can also get a PET scan as well if there's some controversy in terms of what we're seeing on an MR scan. We can also get a PET scan. A PET scan is a nuclear medicine imaging test that actually uses a radioactive isotope that's injected, and later on the body is scanned to detect if there's any disease elsewhere. And in this case, for patients with ocular melanoma, we focus on the liver itself. Sometimes we do see it in the lung and bones as well. So this is a table, again, this is a paper from one of Dr. Singh's former fellows, Dr. Balariv, which kind of looked at the different modalities, ultrasound, the CT scans, the MR scans, the PET scans. Here you can see the various advantages. Here you can see that the ultrasound is most widely available, and this is less widely available, and some of the limitations as well. So this is just a table just to kind of give a perspective of the different tests that we will use in terms of surveillance for patients with metastatic melanoma to help diagnose their spread to the liver. As I mentioned, when we get a CT scan, ultrasound, not everything, if we see a spot or an abnormality in the liver, it does not necessarily mean that there is, that it's something to be concerned about. And here you can see that there are other non-cancer conditions that can cause lesions, these spots that we see in the liver. So things like cysts, hemangiomas, hyperplasia, adenoma. So here you can see the frequency, and you can see on ultrasound what we can see. So again, just because, and sometimes when I see a patient, they'll read their report and say, well, I've got this spot in the liver. And then I have to let them know that most likely it is nothing to be concerned about, because again, it's most likely one of these diagnoses instead. Again, this is another study from Dr. Singh's former fellow. Again, very complicated slide, but I just wanted to just give you perspective. There are different kind of algorithms, thought processes in terms of what if we see something on an ultrasound versus what we see on a CT scan versus what we see on, let's say, an MR scan. And based on that, we use these decision trees. So as a physician, if we see this, we react this way. If we see this, we react a different direction. So this is what these algorithms allow us to do in terms of figure out what next best steps are for patients with abnormalities in the liver. There's no question melanoma. So one of the, I still remember this, that when I was a resident, actually an intern back in 1990, there was a patient with brain metastasis, and I've forgotten the patient's name now, but this patient actually had, and back then, 35 years ago, if you had metastatic melanoma, you did very poorly. And I remember I was a very naive first-year resident. It's July 1991, and there was an in-house consult. There's a patient who had melanoma spread to the brain, and I still remember this today. And it's one of the reasons why I do the research I do. I'm very focused on brain tumor research. I remember the senior resident, and I think he was half joking, but he said, "John, don't spend too much time with the patient because the patient's not going to do very well, not going to live very long." So they really kind of put some perspective and some meaning and purpose. So, my thought is if I ever want to do some research, brain would be one area. And, today, based on advances that we have with radiation techniques, immunotherapy, chemotherapy, we have patients with brain metastasis with 35 years ago that probably lived 4 months, 6 months, now can live years, right? So we have different approaches. And as I mentioned, when you think about how cancer patients do, you really want to get to that next new thing, right? So there's many patients that I see that if they can get to that next 6 months to the year, there may be some clinical trial or new technology that can be used to treat these patients. So in terms of the classification, class 1, you can see survival is much better than those patients of class 2 patients. And with research, we hope to improve these numbers that we see for class 2 patients overall. PRAME is preferentially expressed antigen in melanoma, PRAME. And again, it gives us an idea of these risk stratifications in terms of what's the likelihood the cancer may spread elsewhere in the body, and may also dictate how we should think about surveillance moving forward, because not every ocular melanoma patient, eye tumor patient that we see is going to be equal, right? There's variations. If you look at the room here, everyone has different colored hair, or in my case, less hair, et cetera, right? So each of us look at different things, and that makes up who we are. So we're very unique. And that's one of the reasons why we want to do the research, to help individualize, personalize cancer care. So we think about the future, we want to go to risk stratification. So we want to be able to take the information we know about the biology of the various tumors. You just sort of very elegant talk about genetic testing, looking at things like monosomy for chromosomal 3, this BAP mutation. And this is going to help guide us in terms of how we think about surveillance, and more importantly, how we think about treatment options moving forward. Just to focus, I'm a radiation oncologist, so I just want to kind of give you an idea of some of the new things that we're doing in radiation oncology. So in radiation, we've made a lot of advances. So just like in surgical techniques, such like in medical oncology, we are better able to target cancer. So one way of doing that is what's called stereotactic radiation, which is high dose, high precision radiation. We use this for various parts of the body. I primarily focus on brain and spine, but you can see that's used for other areas: lung, liver, adrenal glands, prostate cancer, other bones, kidneys, etc. And so the goal, so this is our holy grail. This is what we think about. So when we see a patient with cancer who requires radiation, and as Dr. Singh mentioned, one of the things that we want to try to minimize when we do these eye plaque brachytherapies, we want to minimize the side effects, right? The dose to this very structure, particularly the optic nerve, the macula. So our goal is that for any given dose of radiation, we want to maximize control rates. So fortunately with eye plaque brachytherapy, as you heard, we have 95, 99% control rates. We have excellent, superb control rates. The challenge is that we know that for some cases, you're going to have some issues with vision loss. So our goal is, as much as possible, to have this white curve to be very high in this corner. We want the red curve to be over to the right as much as possible. So for any given dose, we want that complication to be as low as possible. So just to briefly talk about eye plaque brachytherapy, I know some of you have probably gone through this, but from the radiation oncology standpoint, this is where we work closely with Dr. Singh, our medical physicist, where we have different eye plaques that we use. So this is an EP917 eye plaque. These blue lines that you see here are these radioactive seeds. So these are like, you can think of like these rice grains. These are I-125 or iodine-125 seeds. So based on the diagram that Dr. Singh provides, our medical physicist will work closely with him and his team to design these plaques to make sure that the plaque will completely encompass the tumor so we get the 95+% control rates and hopefully minimize complications as well. So in radiation oncology, we look at lots of numbers and other things that we look at. But again, the goal is that we want to make sure that we give a certain dose of radiation to the tumor. So we maximize the control rate and also minimize the side effects. So here is, you can see these blue seeds. So in this particular case, there are 10 different seeds that we decided to place, which is shipped to us. And then in the operating room, Dr. Singh meticulously, very carefully places that eye plaque right over the tumor. And this is a diagram. So in radiation oncology, we look at lots of different diagrams. Just to give an idea of kind of what I look at with our medical physicist is this is a cross section of the eye. This is the tumor that's outlined. Here is the lens. So this is a cross section of your eye. All these little lines that you see here represent the radiation dose. So you kind of think of it like a mountain. So the area that's closest to the tumor is the peak of the mountain, and then the dose falls off. So here in this case, our goal is to give 85 gray or 8500 gray or centigrade is the radiation unit that we use. You can think of like inches and centimeters. So we want to give as a high dose of radiation in this area so that we get that excellent control rate. And then based on where these lines fall, we can get it. We have a good idea of, is the patient going to develop a cataract? Is the patient going to lose some vision in that particular eye as a result? Now, when we can't do eye plaque brachytherapy for other parts, so let's say the tumor spreads to the liver or spreads to the brain, we can actually do stereotactic radiation approaches. For those who've not seen a linear accelerator, this is one of our linear accelerators that we use here at Cleveland Clinic. The advances of the linear accelerators now is that it actually has an onboard CT imager. That's actually, now we have something called the HyperSight, which is a very fast way of imaging the patient. We also have a very fast way of delivering the radiation. So for certain spine tumors, for instance, the treatment itself is 3 to 5 minutes. In the old days, it used to be for 5, 6 weeks. Now it can typically do the radiation in 1 to 5 days. So it's very high dose, high precision radiation. We also have different ways of immobilizing patient to minimize organ motion. So here's just an example. One of my colleagues, Dr. Debt, who's a renowned radiation oncologist, does lung radiation. Here you can see a large lung tumor. Here you can see that various radiation beams were focused, and here you can see the result many years later. Durable tumor control. So this patient did not need surgery, did not need chemotherapy to control this large tumor. Here's another example of a patient with liver metastasis. So sometimes for patients who with eye tumors that spreads to the liver, in some cases, if it makes sense, we will do focused radiation. So here you can see the area in purple, and we give a 5 fraction radiation, and we get excellent control rates, upwards of 90% with this approach. We know that the lungs, the liver moves. There's different ways of trying to predict where that organ is going to be relative to the radiation beam. So this is called an ABC, or automatic breathing control device, where the patient has a mouthpiece. They actually have a visual goggles, and they can see where their breathing pattern is. And based on the breathing pattern, we hit the tumor as that tumor is hitting the target, where the radiation beams are aligning. So this is where we use technologies. And here's just an example of a spine tumor that we treated. This is what's called a dose volume histogram. So this is kind of what I tell patients. This is kind of like a report card of how well we've done in targeting the tumor and minimizing dose to the normal structure. So this is the dose. This is the percent coverage. So for a tumor, we want 100% of the dose to get a certain dose. And these are other normal structures. So again, as much as possible, we want to push these lines over this corner, and we want this line, the tumor line, to be focused more over to the right. As I mentioned, I focus mostly on brain tumor patients. That's the majority of where I do my clinical research, education, and we're very fortunate in that we have a very active gamma knife radiosurgery platform. This is one way of delivering this high dose, high precision radiation with these cobalt-60 sources. We had distinction being the very first center in North America to obtain this particular device. We actually have 2 gamma knife units side by side. And so with the Gamma knife, we're able to give these very, very high dose of radiations. This is just a cross section. We now can use a mask or a metal frame. The patient goes inside the machine. These are these tungsten collimators, these holes, 192 to be exact, that target this high dose radiation. And for patients with melanomas, we can get upwards of 90% local control for, again, selected patients. We treat this modality. So in summary, imaging is really important when you think about surveillance for patients with metastatic melanoma to try to figure out if there is spread to the body. The frequency and timing varies a little bit, but as we better understand the biology, we better understand how to treat patients who have ocular melanomas, we can better figure out how often, what the best imaging devices are for these patients. There's no question advances in melanoma. This is very, very exciting time for patients. If you are diagnosed, there are options, which again, when I started 35 years ago at Cleveland Clinic, the options were very few and far between. So there's definitely hope for patients and families with ocular melanomas. And then personalization is going to be very important. And we are very fortunate to live in an era now where, my predictions next 5 to 10 years, you're going to see some tremendous advances in how we think about cancer care because artificial intelligence. I mean, if you look at our phone, the phone is super. I mean, think about how much advances the cell phone has made over the past 10 years. It's quite remarkable, right? And I imagine 10 years from now, the cell phone is probably going to be unrecognizable with what we see today. And that's what's going to happen with medicine as well. So thank you very much for your attention.
All right, we have about 10 minutes for questions, so I'd like to invite all of our panelists up to the front, if you wouldn't mind. And we have some of our volunteers who are going to be walking around with the microphones. We will also be taking questions from our virtual attendees. So anyone who's joining us on Zoom, please use the Q&A box and Miriam will be fielding those questions. So I think we have our first question over here. If we could bring a microphone just right over here.
Me? Oh, okay. This is a question for Dr. Su. I was just wondering what your thoughts are in terms of ctDNA blood biopsies. My local oncologist, medical oncologist sometimes does that. And I was curious if there's been any advancements in terms of how accurate that is. And I guess showing metastatic disease before, let's say an MRI or CAT scan can show that.
So ctDNA or circulating DNA is where you take blood and you look at the DNA to see if there's any DNA fragments that are elsewhere in the body. And studies have shown that it's really a very good way, and actually I would predict it's going to be more and more common in terms of trying to predict if a patient has disease elsewhere in their body. There's lots of research ongoing, and my prediction is that the ctDNA will perhaps replace some of the imaging studies that we're using today. And if you think about it, it's much easier to draw some blood versus going through all the imaging. And the cost still could be a barrier right now, but as we get more and more studies, it's going to get easier. We're going to better understand how ctDNA works. And again, as I mentioned, in terms of cancer care, it's a very exciting time in the sense that there's lots of advances that are being done, research that's being done. I'm going to defer to the esteemed panel here in terms of how they think about ctDNA when it comes to ocular melanomas.
Specifically about uveal melanoma, this is an exciting area of work, but right now it's not in clinical usage. So we know that the patients have micrometastatic disease, tumor is circulating. Uvea is the most vascular tissue in the body. There isn't any other tissue that has more blood flow than the uvea. So uveal melanoma is basically in blood. The whole choroid is all capillaries. So these tumors are circulating, and some may be dead cells, so just the tumor DNA. So the sensitivity of finding it depends on the technologies, and they're getting better every time. So right now, maybe you need 20 ml of blood to find something. Eventually, it will be a smaller amount of blood, you'll be able to find the DNA. But to correlate that with the patient's outcome, detection of metastasis is a process, right? So it has to be long-term studies, and that's ongoing, and will get better. But I want to highlight one aspect that's already known, and that came from Kim Track Tebi Tabantafest trial. Anybody from Immunocore here? No, Immunocore, no. Anyway, Immunocore is the company that did the trial. And somebody from Immunocore? You're from Immunocore? Yeah, you know about the TEBI trial, right? And so one of the predictors of the response was the ctDNA in the blood, right? You familiar with that at all or no? You able to comment on this aspect?
I can comment somewhat.
Okay.
Can we grab him a microphone just so our
So-
virtual attendees can hear?
So they are looking at the tumor size in the liver, and you're looking at the outcome. So it's the smaller the liver's lesion, the size of the metastasis in the liver, better the more likely the response to tebentafusp in the trial. And the second predictor was the actual amount of ctDNA. And those patients on whom the ctDNA came down after treatment, they did better. So there is some correlation already known, but that's in patients that already have metastasis in terms of response. But in terms of predicting who will get it and when that happens, that's not established yet.
Do you want to comment?
Yeah, I mean, what I can say is I appreciate Dr. Singh's enthusiasm about ctDNA. We obviously share a lot of those same views. You know, but again, the concept of ctDNA is still evolving at this juncture. And we hope that over time will give us a lot more guidance on how to manage patients, but we're just not quite there yet.
Great. Next question.
If I could ask a two-part question, yeah, I would be that guy. So Megan, you had a slide that mentioned the biopsy, doing a biopsy on the tumor could affect or give guidance on treatment options. Is that frequently or rarely? And then for Dr. Su, you had a slide that talked about both class 1 and class 2, and frame positive and frame negative. Could you explain, for example, if there is a correlation between class 2 and frame positive, if that means something?
Yeah, I was going to say, I'm actually going to defer your question to Dr. Singh,
Okay.
since he's the one doing that.
So the first question, biopsy and the type of treatment. I would say that there is actually no such thing in my view. Some people can argue that if I did the biopsy of the tumor and tumor comes out to be, say, class 1 that has a low risk of metastasis, and then you can therefore don't have to treat it, you can just observe it and then treat it later on. That being the logic. But class 1 and class 2 only reflects one aspect of the tumor, and that's the risk of metastasis. Class 1 and class 2 tumors look the same. They can be same size, they can grow inside the eye, they can cause retinal detachment, they can take away vision, they can even spread to the orbit. So therefore you say, I want to just observe class 1 tumor. I think that's misleading because the tumor will grow and will grow into the orbit, for example, or can take away all the vision. And from plaque therapy that you could do initially, you end up having enucleation or even more complicated surgeries. So I would say that the biopsy should not really guide your intervention as far as the eye treatment goes. So that's the first question. The second question is about this PRAME, and there's some recent data, and I'm going to highlight that. So one can say that these class 1 and class 2 are good classification systems. You have patients with low risk and high risk. And the numbers will vary as time goes on. Different data sets over time will refine the numbers better. But roughly one can say class 1, approximately 5% risk of metastasis, and class 2, approximately 70%. And this number may be slightly up or down as time goes on. And the PRAME status is a risk modifier. So if you have class 1 PRAME positive, class 1 PRAME negative, and you have class 2 PRAME positive, and class 2 PRAME negative. So you can have 4 groups. So within class 2, if you have PRAME positivity, it worsens your outcome. And same thing in class 1, if you have PRAME positivity, it makes it worse. So no matter where PRAME comes in, it worsens the risk of the groups. but by itself, is it enough to segregate good from bad? Okay, something like that.
All right, we'll take probably 2 more questions from this audience, and then we'll see if there's any online before we go to break. And then at break, you all can ask more questions as well. So.
Okay, my question is, so I had an enucleation by Dr. Singh, and it was diagnosed as a class 2. So my question is, does that change the prediction of metastasis because the eye was enucleated and the cancer was removed? And then I did hear during the presentation something about reoccurrence with enucleation. I didn't understand that at all. Does that make any sense?
Yes, both things, very important questions. Let me answer the second question first. So one can say the eye has been removed. How can the tumor come back? And that there's nothing left there. Well, there's still orbit there. And sclera, which is the lining, the white lining of the eye, is a barrier to any kind of tumor spread outside. But sclera has tiny holes in it through which the blood vessels and nerves come and leave the eye. So there are tiny microscopic holes, like channels for the wires in a ceiling or roof, wherever. They're coming in and out of the eye. And the tumor can grow from those existing channels outside microscopically. So when the pathology report comes back, say all margins negative. That's almost always the case. But there can be some microscopic cells that have been overlooked or not detected, and that can come back in the orbit over time. That will be highly, highly unlikely, but we have had like 1 or 2 cases. And in the biggest study, the COMS study, the data was approximately 2%, but that was way back in 1990s. So I would say that nowadays it would be less, but yes, it can happen. So that's the second question. And the first question was, did the class 2 plaque radiation versus enucleation, does that impact the outcome? So we say within class 1 and class 2, size of the tumor is also an important modifier. By itself, classification of GEP is more important than the size, but just like frame, size also modifies it. So if you have somebody has a class 2 tumor that happens to be small, they're going to do much better than somebody who has a larger tumor with class 2. And there are studies to show that the prediction that's coming out is actually worse than what it is. So the prediction that's written by the company is more pessimistic than what is observed. So there's also, so the numbers are not that precise. They will be downgraded, I think, with time, but the classification is quite valid. So the treatment itself doesn't matter. It's the tumor size that will drive it. Yeah.
All right, one more question here.
Yeah, John, my question's for you. And look, probably one of the most important things for someone with OM is about the surveillance, the systemic surveillance following. And everyone obviously wants to know and ensure as much as possible they don't get metastases and they're found early. But the issue is, I'm a physician who also believes in evidence-based medicine, and I'm noticing your slide, you use the words hope. So I'm going to ask you what the quality of the evidence is around the benefits of early detection. And in particular, I also wanted to ask about the evidence at the moment that suggests that 5% of cancers in the US are caused by CT scanning. Should CT scanning still be a part of current surveillance, particularly in younger patients who've had ocular melanoma?
Okay, I'm going to answer the first part of it. And the second part about the CT-induced cancers, I'll leave it to Dr. Su because the radiation oncologist. So we have done, I think, the only work in this field trying to get the evidence, and you're asking about the level of evidence. So right now you have a lot of opinions and a lot of guidelines, but very little evidence. So what we did, we looked at the patients, class 1 and class 2, because I think that clearly defines the risk. That is a risk stratification. So class 1 patients should be surveilled in a different manner than class 2. And I think that's very clear. Most of us will accept that. In class 1 patients, we say there's 5% risk of metastasis. That means out of 100, 95% would not get it. So all we're doing these scans is to find that 5%. And we did a recent paper which came out yesterday online. I will say that 985 scans were done and 980 were negative. So you're spending, let's say, 1,000 scans on many patients over time. Only a few percentage point will come on. Maybe it's worth it because people want to know their status. So in a low risk case, you say, I want to do something that's least invasive. So I would say ultrasound is very good for that. And frequency, and there are studies to show from other parts of the world, that every 6 months will detect practically everything that's to be detectable. So for low risk case, we do by default the minimum, which is this. If for some reason the risk estimation has not been done, then we'll also stick with a low risk kind of surveillance. So to us, that's pretty good. We have done some studies on it. And if there is a doubt on ultrasound, you confirm with MRI followed by biopsy. So it's like a two-step thing. And that's practically covers everything. Now, will that translate to patients who had better outcome because the metastasis was detected in class 1? You're going to have only 5 patients out of 100, and you can never prove that statistically. So leave it at that. Come to class 2. Then you can have here 2 kinds of approaches. We try to kind of say this is enhanced protocols. That's a standard protocol for low risk. And you say enhanced protocol for high risk cases. I think they deserve more surveillance. I get that part. Because smaller the liver size, liver metastasis, more responsive you are to DeBenedictis first and other drugs that may come along. So there's a reason to find liver metastasis early. That's fine. So you say, okay, you can have either high frequency, which is every 3 months, or enhanced modalities such as CT or MRI, because MRI can, CT can pick up tumors smaller than what ultrasound can. So you can use one of those 2. And so we compared these 2 methods with each other, and we found that high frequency is as good at enhanced modality. That means doing CT MRI every 3 months is as good as doing ultrasound every 3 months. But ultrasound 3 months and CT MRI every 6 months, they are not better than each other. So I would focus with frequency rather than modality. So it takes you away from CT MRI. So that's one thing. But another patient asked me, well, it's only 90-day difference, 33 months versus every 6 months, right? So if you didn't do it every 3 months, you did it in 6 months, you're delaying the tumor that was present detection by only 90 days. Will the 90-day make a huge difference in patient's outcome? I don't know. But if you get mental peace from it, then I would stick with high frequency rather than enhanced modality. This data is published. All this is published now. Just recently published.
So you asked a question about the use of CT scans inducing other cancers. So what I would say is that when we think about scanning, we always think about what is the risk versus the benefit, right? So the data, as Dr. Singh just mentioned, is that in terms of the frequency, the type of imaging modality, there's no consensus. It's really physician kind of driven a little bit and based on some research that's being done as well. So in my mind, in terms of, and this is a discussion that, I think as patients and families, I think it's always important to know what your options are, right? So if you said, look, there are patients that I see, for instance, their number one goal because of who they are, they want to know as much as possible, right? So as we heard, ultrasound gives just a snapshot of what's going on in the liver. If you do a CT scan, you get a much bigger, you get idea of what's going on in other areas, bones, et cetera. So for some patients, that gives them peace of mind. And for that particular patient, maybe that's a better option overall. In terms of this question of whether or not the CT scans, we do know that imaging can eventually lead to some type of tumors or even cancers. And again, my mind is always that risk-benefit ratio. So if you have an imaging modality that allows you to pick up something sooner, right, is that going to provide better outcomes overall for that patient versus if you don't pick it up sooner? The jury's still out on that. What I would say is, in my mind, with the type of, I do this high dose, high precision radiation. If we can detect something that is smaller, it is easier for us to treat and get better outcomes versus something that's much larger. So the analogy I like to use, which is not a perfect analogy, is like, for instance, in the brain world, if I had a marble and the radiation I'm going to do is a hammer, I can pretty much break that marble up with the hammer. If it now becomes a golf ball, and I try to break that up with a hammer, it's much harder to do. So then that's where that benefit, that risk benefit, is that I showed you with those curves, that therapeutic ratio, what's your chance of controlling versus what your complication rate is. So certainly the information that was put out there is provocative, like, well, should I get CT scans, et cetera. My personal feeling is, if you have the diagnosis of cancer, we want to do what we can to try to better understand if it's spreading elsewhere in the body. And if the CT scan is the preferred modality, then that's what you should do. If you don't have cancer, then if you think about lung, a perfect example, for the smokers in the room, there are studies that have shown that if you do CT scans, guess what? You pick up that patient with early stage lung cancer that's curable. If you didn't do that CT scan, you don't detect that patient, it spreads their lymph nodes, their bones. They're most likely not curable. They probably will not live around. So again, it's a work in progress. My prediction is that as we get better information, and this is where AI is going to be very important here at Cleveland Clinic, we have access to what's called quantum computing, these very high speed processing computers, and it's going to help us do things that we're not able, that myself, for instance, not going to be able to do these algorithms really quickly, but perhaps these computers can help us with. But it always becomes a risk benefit ratio. For those of you who think about radiation, when you fly across the Atlantic Ocean or Pacific Ocean, you get radiation. You step outside, you get radiation. So I think unfortunately, radiation has this very negative connotation or meaning for patients. Like, oh, if I get radiation, I'm going to get this. But radiation is also a very, very powerful tool. And hopefully we've been able to show you that for patients with these ocular melanomas, we get terrific control rates. And for many of these patients, they can preserve their eye. Some of the patients do lose their vision, but again, it becomes, do they want the enucleation versus radiation? I mean, there's options available, and that's where the studies can come in.
Great. Let's take one online question, and then we're going to go to our break. So Miriam, if we could get one microphone over here, she's going to read the online question.
Okay.
It's on.
Hello. No. Regarding scans and surveillance in someone with a SF3B1 class 1 tumor, would surveillance be increased at the 7 to 8 years when risk for mets supposedly increases?
That's a very, again, interesting question. So first of all, we say it's a class 1 patient, so low risk of met. And most of the metastases, if you look at the older literature, what happened within the first 5 years, and maybe some up to 10 years, and after 15 years, you're statistically cured from uveal melanoma. And I stand by that analysis, which is my own analysis. Okay, coming back to this SF3B1 mutation. So this correlates with a little bit later onset metastasis, and that risk is certainly there from 5 to 10 years. So I would also look at patients' own age. So average age of diagnosis is 65, say somebody happens to be 75, after 5 years they're 80 or 85 years old. Then you have to wonder how useful are all of these scans. So it's not just the time since treatment or the diagnosis is one thing, mutation status is the other. And I mentioned, frequency. So instead of making it once a year scan after 5 years, I would stick with every 6 months if somebody has SF3B1 mutation, because ultrasound has no side effects. Does not require any IV. There's no X-ray. There's no contrast. So no matter how you do it, it's very safe. It's cheap. It's easy to do, close to phase 1. But I will do that specifically in a patient with this scenario who happens to be young. But if somebody was already 85 years old, I'm not so sure. Want to do more and more testing.
Great. Well, thank you. Let's give a round of applause for our excellent panel. Thank you all very much. We are going to have a